Hello, my name is Matt Swift. I'm a cardiac scientist based at the Great Western Hospital in Swindon. Today we're going to talk a little bit more about remote monitoring, how we set these services up, the benefits for patients, and how our service coped with the COVID-19 pandemic. In 2009 we decided that we were going to move to a remote-based system for the majority of our device patients. The main reason for this was a capacity issue that we have in our department. Although we're well staffed, we're short on space, and if we could perform device checks remotely, it would free up capacity for us to do other diagnostic tests such as echocardiography. In that time, over 10 years, we've performed over 30,000 remote device follow-ups, and the service has changed no end. Currently we're performing approximately 1,400 remote device alerts per month. When the service started, we saw the remote interrogation and remote follow-up of devices as complementary to our in-clinic follow-up. Over time this has changed, and we now really see in-clinic follow-up as a complement to the remote-based service, which allows us to target the patients that we need to see face-to-face in clinic. It's also allowed us to alter our working practices. Like today, I'm working from home, doing my remote clinic from home and actioning the alerts all from home. When I get asked by colleagues for advice on how to set up remote-based services, I stress to them that the service that I present to them today is very different to the service that we started off with 10 years ago. The one thing I always advise people is to be explicit with your patients at implant as to the limitations of the service. For patients, the simplicity of the remote monitoring device is the most important part. Having an implantable device implanted, although for the doctors and the physiologists is an everyday occurrence for a patient, this is a really big day in their life, and there's a lot of information they're going to be given and going to have to take in on that day. So the setup of their remote monitoring box really needs to be as simple and as straightforward as possible. All services doing remote monitoring should also have information leaflets that they give to patients, explaining how the box works and how the information is dealt with as well by the team at the hospital. One of the most daunting parts of setting up any remote device service is the management of the alerts that come through. We're very careful to program these alerts at implant in line with the patient's indication. For example, patients with known atrial fibrillation have those alerts turned off at implant, but we leave on the alerts that would reflect high ventricular rates during AF, which may be an important heart function parameter. It's important for services to have clear pathways of referral once they get these alerts, so that they know and have standardized procedures as to what they're going to do with them. An example of this is our non-sustained ventricular tachycardia pathway. If we detect a non-sustained VT in a patient that's greater than 24 beats, or we're having runs of VT throughout the preceding month, we look at the patient's records to see if they've had a recent echo. If they have had one and they've got a known LV dysfunction, we forward this on to a consultant cardiologist. If there's no recent echo, or they've got a good left ventricular function, we send this information to their GP, their general practitioner, who then filters the patient onto our BNP pathway. So they have a blood test where the BNP is measured, and if that is high, they then are referred to the hospital for an echo and assessment of their LV function. About 2 years ago, we decided that we were going to utilize the heart function diagnostics that get sent through by devices by taking the in-time study and applying it to our entire patient population. So this is a multi-parameter based process where we look at thoracic impedance, mean heart rates, patient activity, and if we start to see trends which indicate heart function issues or heart failure, we then forward this information on to our nurse-led heart function team, who contact the patient, and if needs be will make an intervention, changing medication, or we've even had numerous patients who've been admitted directly to hospital from the community for IV diuretics. When I was sat at home over New Year watching the news, and you see the first reports of this unknown pneumonia emerging from China, I never envisaged that this would lead to a global pandemic which would massively alter our device services and how we can offer them. We took the decision in late February when it became clear that COVID-19 was going to cause a real problem for our device service, that the remote monitoring service was going to take the burden of patient follow-up probably for the next year. The issue with doing this is that the patients that we need to see more regularly, that are often on enhanced follow-up for battery, have older devices and therefore aren't on remote monitoring. So we utilised a clean clinical site, a second hospital, where we'd see these patients as and when they were needed. We placed all of our patients who have a remote monitor onto a remote-based follow-up for their device check during the periods between March and the end of May of 2020. This allowed us to aid patient safety, and it also helped us with staff safety as well, and allowed us to observe the government guidelines of social distancing. We put more staff on remote monitoring so we could work from home where possible, which is one of the government guidelines. Now the peak has passed in the United Kingdom, and hopefully we don't get a second peak. We're starting to move towards this new normal, or as they call the post-COVID era. And this has seen a large change in the way that we can follow up patients in clinic. At the moment our clinics are running about half capacity, so we are utilising the remote monitoring service to sweep up the vast amount of patients and patient follow-up that we need to perform, and that I think is going to continue well until well into 2021.